I was asked to give this talk today. Hopefully it is relevant to your practice and will be relevant to your practice in the future. It's quite a focused talk actually around a single molecule in a really complicated disease. But as a member of the National Institute of Health Research, we've been putting a lot of effort over the last 10 years to try and look at this molecule and do health services research in both children and adults to try and work out whether it really has value and importance for care. So that knowledge has now been brought together and has been presented to NICE, and they will be considering this, as you've heard this morning, around new guidances, which will not just be about procalcitonin. And I've just noticed online that that is hoping to be delivered by the 21st of September. So they've put something, a line in the sand. So there you go. Please look on their website for more details. So I guess I better talk a little bit about why we've done this research at the NIHR, because it did come out of some previous NICE guidance from 11 years ago, a long time ago. So I'll just allude to that. How does that guidance currently apply to your practice? Because of course that's the guidance that is partially governing what your hospitals and communities ideally are supposed to be doing, and particularly when the CQC inspect. And then what's the evidence that might change the dial on this? And I don't work for NICE. I don't know what decisions they will make about this evidence and knowledge that I'm going to briefly talk about today. But the critical thing is it's, I would hope, trustworthy knowledge that has been produced by our community in the United Kingdom, in the NHS, funded by the NIHR with the quality mark that brings. Now, I have no commercial funding to declare, and I think it's important when I'm talking about a molecule that actually is provided through commercial providers, that I'm up front and say, you know, I'd like to believe I'm an honest broker, and I came into this with a position of not knowing what the answer was, and I think that's really important. So one of the things that I learned quite early is that if we're going to use markers to provide decision support in our care, what is the actionable question that we're really interested in? Now, we've heard that sepsis is incredibly difficult to screen for and to diagnose. And in fact, the current guidances, both NICE and the global guidances, the Surviving Sepsis campaign, do not recommend any marker to use as a diagnostic in sepsis. They don't exist, and so I'm not going to pretend what I'm talking about today is diagnosing sepsis. But the really critical, actionable question, because we kind of know what to do in sepsis, and that is something about giving antimicrobial medications in a timely fashion, and then doing things with those antimicrobial drugs that is around medicines optimization. So this should hopefully interest Diane, because this is absolutely bang on patient safety and pharmacy. So this is very much about antimicrobial stewardship. When do we start antibiotics? When do we think about refining them? And when do we stop them for patient benefit in the sepsis care pathway? So that's what I'm focusing on today. You will know, you've had a talk about this today from Ramani, and we are in connectivity with Ramani from the NIHR, that we've got a modern service framework being evolved, and part of this will be an expectation to apply NICE guidance, and indeed any other guidance that is relevant, particularly international guidance that I'll allude to, and Emma talked about actually earlier today. So quite important, I think, for sepsis, and will be one of three, I think: mental health, cardiometabolic, and sepsis. So these are the three things the government are running with at the moment. So in terms of NICE, well, there's loads of guidance. You heard that this morning. You know, we have early treatment guidance and screening guidance for both adults and children. And the diagnostic guidance is at the bottom here. One is around what we call pathogen diagnostics. So these are rapid diagnostics that find the bug. And you've heard some talks today about the kind of really neat things that are coming along for the future. We have at the NIHR 2 important clinical trials using rapid pathogen diagnostics, one in bacteria in sepsis and one in fungi in immunocompromised patients with sepsis. I'm not going to talk about those today, but perhaps in the future we'll come back and tell you about the knowledge that's been produced from those big studies. We're going to focus on this red area, which is procalcitonin. Now, procalcitonin, you're probably aware of procalcitonin. It may or may not have been available to you over the years in your setting, but it's an inflammatory mediator. So if you have surgery or have an infection, procalcitonin within 24 hours goes up. It goes up particularly high for bacterial infection, but it also goes up in a surgical insult. And as you get better, as the surgical insult fades and your inflammatory system settles, procalcitonin falls very quickly, and that's also the same when antibiotics work well for bacterial infections, that very high level of procalcitonin falls pretty quickly and gives you an indication that your treatment's working. So it's always been thought of as a circulating, measurable protein that might help with decision support around when we're making these difficult decisions with patients. So the original guidance for procalcitonin from NICE was about 11 years ago. This is still available online. And there was a really big effort done actually using independent systematic reviewers to look at the available evidence. And it was quite compelling 11 years ago actually, but it was felt that that evidence might not apply to the United Kingdom. And you might think, oh, well, we're very special, aren't we? Well, we are very special. And I would argue that we're pretty good at doing antimicrobial stewardship. Diane might disagree with me, but we have very good frameworks. And certainly in intensive care, I will see pharmacists and microbiologists, infection disease specialists very frequently, sometimes on a daily basis, sometimes every other day. And we meet together and we think about the patient in front of us, the information we've got, and we like to think we do good things with antibiotics. And of course, the downstream effects is to look after antibiotics, isn't it? Stewardship, so we can use them in the future and we don't have resistance. So compelling evidence, but NICE didn't feel that they were quite in a position to say this is going to be good, particularly for judging how long we give antibiotics for. So they recommended definitive research, that research should be done in routine care, and that research should include adults and children. Okay. Because there's supposed to be a bit of a system that talks to itself, the NIHR picked up those research questions and made independent judgments that those were really important research questions to address. And so they prioritized funding to do large-scale definitive trials. And I'm going to describe 3 of them right now in brief that have completed and have reported. Oh, and I think Emma also talked about a month ago the new global sepsis, surviving sepsis campaign have released their guidances, both for children and adults. And I have to say that our NICE guidances a little bit behind these new global guidances, and it's probably a bit of one of the reasons that NICE needs to look at this. And in those global guidances, this is a diagram that I've borrowed with permission from the adult sepsis care pathway. And we heard from Emma earlier that screening tools are not great, but we should have tools to try and make decisions about risk. And she described that very eloquently for children. In adults, I guess you're familiar with using the NEWS2 score, certainly in a hospital environment, and it's definitely promoted in the community as well. These guidances say, well, those tools, there's no one is better than another, but one of the good things I think we're good at in the UK is sticking to one tool, and I think we heard that eloquently from Emma around the paediatric early warning, and definitely for NEWS2 for the adults. So I think we're quite good at that. To put some sort of risk statements around this rather nice diagram which says, if the patient in front of you has shock and you think it's because of an infection, give antibiotics immediately. If the patient in front of you you think is highly likely to have an infection, doesn't have shock but has signs of sepsis, give the antibiotics quickly. If the answer to those questions is you're really not sure about the risk, it may be you've got time to think carefully for a few hours about your use of antibiotics. I think that's a really hard-yard statement, but I think is supported by the evidence. So it's sort of trying to find that group of patients that need antibiotics quickly, and I think we heard that from Emma, that small number of children that could, at real high risk of getting sick and ending up with septic shock, and probably a bigger group of adults, as I'll come to. But there's no markers in there. Now, a study that was published about 3 weeks ago that you might have seen called the Pronto study, I talked a little bit about it last year, is really quite important for NICE to have a look at. So there is a QR link to the paper there. It's very technical, but is a very clever and elegant study. So this was in adults presenting to the emergency department with a suspicion of sepsis. And to judge risk of sepsis, the NEWS 2 score was used and was, and you can see, you might be able to see this, you can certainly see it in the paper. Patients were binned into low risk, medium risk and high risk based on the NEWS score. And 7 and above, if you're interested, is very high risk. Okay. So half the patients at random were managed with a complex intervention of seniority, review, early or late antibiotics, depending on that risk. The other half at random not only had that risk score used, but they had procalcitonin used as well to add to that risk score. So a really interesting study. That was conducted in over 7,000 patients in 20 hospitals around the country. I heard somebody was from Derby who were particularly good performers. I don't know if you were involved in this study. Some of you may be, in the emergency department. So really interesting study. So I'm going to show you the headline results. On the right side is a sort of a wiggly curve that actually is the two groups overlaid, because there was no difference in the use of antibiotics in the emergency department in those two groups. So one of the primary objectives was to find a difference. But the other co-primary outcome was about mortality up to day 28. And what was absolutely fascinating in this study is there was a mortality benefit by having procalcitonin measured. So that sounds a bit counterintuitive if the antibiotics didn't change, but people got better. So something about having procalcitonin measured was really important in this study. About a 3% difference in mortality, really important difference, that if this was a drug, we'd probably be recommending it very soon. Now, if we look even more carefully at the patients that benefited the most from procalcitonin, it was in the high-risk group, so the red bar on the right here, the NEWS score of 7 and above, and those particularly that came from environments of deprivation. So isn't that interesting? A measure of somehow we could do better and save life in that group of patients. It's a nice editorial with the study because they couldn't work out mechanistically what's going on, but I think most of us believe that the use of procalcitonin in that setting is getting clinicians to do other important things. So when procalcitonin is low in that group, they're thinking, well, is it really sepsis? You know, have we missed the heart attack or the ruptured bowel or the pancreatitis? So really interesting result, and it'll be interesting to see what NICE say about that. Now, this is a study in terms of how do you refine your approach with procalcitonin. This is a study that was actually performed with some of our colleagues in Copenhagen and Denmark some years ago. It's a really important study. And this was in intensive care and for using procalcitonin to escalate antibiotics, so measuring it on a daily basis. And as soon as it went up, was to start antibiotics in those patients, hit them hard, and it wasn't until the procalcitonin came down that they stopped them. That approach was dangerous. And it's a really important paper, this, because it didn't make any difference to patient survival. But that approach worsened organ dysfunction and kept patients in hospital longer. So that isn't something that I think NICE are going to promote us to do. And I have seen procalcitonin used in that way in the UK. So a word of warning. But in terms of this daily review with procalcitonin, you know, what are we going to do with it? And I'm going to talk about briefly a bit of evidence that I mentioned last year. But the current guidance, the global guidance, says that, you know, we should have high quality daily clinical assessment, okay? And I think we've heard that from Emma. That is also true in adults. This is a clinical diagnosis and needs careful clinical review on a daily basis. And procalcitonin doesn't replace that. We need adequate source control. We've heard a harrowing story about a line infection. Absolutely gold standard to sepsis care is to get source control, whether that be surgical or line removal. That is a absolutely A-star thing we need to be doing. So that's in the international guidances. Simple stuff, but we've got to do it well. Tom this morning from Newcastle, a colleague of mine in intensive care, talked about how can we reduce burden of antibiotics, how can we shorten the duration. And Tom's doing a beautiful study in our community, he probably described it this morning, about how we're just simply trying to give short courses, a really challenging thing to do for individual patients in front of you. So what we really need to be able to do is personalize our approach based on all of those good things, but then using something that can help us deliver shorter antibiotics. And I'm going to talk now very briefly about how this has been tried in children and how it's been tried in adults. So the batch trial, which was by our, led by our pediatric communities around the country, and you can see that, a really big trial, 2,000 studies, led by a colleague of mine, Enitan Carroll at Alder Hey, unfortunately didn't produce any advantage to children with high risk of bacterial infection. Most of these children were on the ward, had readily treatable infections in the setting that Emma described, really high quality review. So the addition of procalcitonin for that group of patients made no difference to how long antibiotics were prescribed for or whether they survived or not. So NICE will be looking at that to make determinations in that patient group about whether it's relevant. And then I talked about this trial last year, which was the big one we did in adults. So this is adults from that News 7 that went to ICU that have procalcitonin measured on a daily basis, starting in the emergency department and then on into ICU, and using that as decision support to try and work out when it's safe to stop antibiotics. And there's a QR code there if you want to see it. And the take-home message was that we were successfully able to show that procalcitonin made a difference to antibiotic duration, and in fact CRP didn't. The trial was quite a complex trial because we blinded the intervention, you may recall, so clinicians didn't know where the advice was coming from. And the reason we did that was so we didn't disadvantage routine stewardship, which we thought was very strong in the UK. And what you can see here is that in the setting of high quality stewardship, procalcitonin daily, surprisingly to us, adds on to that and saves some duration. We've since gone on to do a meta-analysis of all the open label trials, and you can probably get up to 20% reduction in antibiotics by using procalcitonin on a daily basis in those high-risk critically ill patients. And you're going to ask me what was going on in the control group. What is the usual prescription of antibiotics in this group? And around the world, on average, it's 10 days. And I know you think that's unthinkable. I'm surprised that I give 10 days of antibiotics to somebody with sepsis. But actually we do on a daily basis, and the evidence is there. And the use of procalcitonin can, with an individual patient kind of precision approach, get you to think very carefully on a daily basis to make decisions about stopping. Is it safe? The evidence is that it is safe. So there's no mortality difference between patients that receive that intervention or not. And patients are really keen to see these data, because if we're going to reduce antibiotics, it has to be safe. And finally, is it cost effective? So one of the key things that NICE want to know is if this kind of evidence is utilizable in the NHS by your very good selves, is it going to help in terms of cost effectiveness? And I'm not going to go through the calculations that NICE do, but this was by a NICE economist that worked with us. And he made a very nice calculation from all the available global data that additional quality adjusted life year, which is NICE want to work out how much is it going to cost, is £2,000. That's well below their threshold of £20,000. So if you stack this up against dementia treatments, this is a highly cost-effective intervention. So I'm going to stop. This is my last slide. I've just gone through what I think is the important evidence, or some of it, that NICE are going to be considering over the next few months. They've announced that that's going to happen. You heard it first here from our speaker this morning. There's various mechanisms that will happen, but at least the first of those guidances, I think there is a commitment to try and get that completed by the 21st of September. Thank you very much, Diane.